Evening to all of you. And it's really nice to have all of you this evening. Just for the ease of not losing my internet connection and having glitches, I've recorded the version so that it plays seamlessly. And because these are 4 major groups of symptoms that we have to discuss, so it is so each one is a CME in itself. So that's why I thought I'd just play the recorded version, which I had recorded and sent it to Rajalakshmi. What I would encourage you to do is, as you're listening, if you have questions, please put it in the chat box so that I can simultaneously answer the chat box, because there may be some thoughts, some case discussions, some problems. So just keep typing it into the chat, and between me and Rajalakshmi, we will try and answer all as much as we can. So welcome to all of you, and hope you gain something out of this session. Thank you so much.
Thank you, ma'am. I'm starting the video. If it is not audible, let me know.
It's going to be a rather long monologue, and I really apologize for that, but there is really no other way that I can do this. So the symptoms today that we will be covering are fatigue, insomnia, anxiety, depression, and pain. So the way I thought about this was that we would do the theoretical aspects comprising of terminology, the concepts, the assessment, evaluation, and focus more on this and just touch upon the principles of management and then think of an integrated care plan. And at the end of the session, we could get some time to share our experiences and discuss patient histories. So I'll start with fatigue. When we think of fatigue, it is one of those symptoms which is a very, very frequent system, but it can be very debilitating. But very often we underestimate the importance of fatigue and the impact it has on the patient. So if we need to define it, it impacts all the domains, the physical, the functional, the psychological domains, and it results in an inability to perform all your daily activities. It affects your mood, social relationships, work. There is so much to fatigue, but there is so little that we always do about it. So that's why fatigue is common. It's complex, it's multifactorial, it's unstable, dynamic, and very subjective. And most importantly, it remains underdiagnosed and undertreated. And it's not just the physical
Pardon, madam, can you increase the volume of the video?
Mental fatigue.
Pardon?
So you can have impaired.
Can you increase the volume of the video? Is it possible?
Let me check one second.
Okay, because it's not audible so much. Or my problem.
Mental concentration, you can have loss of memory, you have emotional liability, all of this with fatigue. I'm not even touching on cancer related fatigue because that's a chapter of its own. So when we look at fatigue in all these domains, we also need to think about what actually contributes to fatigue. So when we have a whole lot of causes. Most of the time we live in that misconception that it's only cachexia that causes fatigue. So suppose a patient has lost weight, is deconditioned, cannot get up, that's when he has fatigue. But we do see fatigue in patients who are well preserved physically. So for example, I apologize again because most of my examples will come from cancer as I work in a cancer institute. So when we see patients with early breast cancer, with lymphoma, with infections, we still see them with fatigue. So it's not mandatory that that cachexia is always predisposed, is always the predisposer to fatigue. But of course, along with cachexia, we have other contributors like inflammation, polypharmacy, symptoms, therapies, tumor byproducts, and anemia. Very often we underestimate anemia, which is a very important contributor to fatigue. Infections, comorbidities, all of this can contribute to fatigue. And in respiratory disease, this is one of the interesting frameworks that we can see. So if we look into this, if we divide it into the A as the A part of it, then the B, the C, and the D. So what is the A part of it? The A part of it are all the controlling factors for fatigue. So what controls fatigue? So again, we look at this in the macro level and then move to the micro level and then the domains. So in the macro level, we have a patient with dyspnea, we have a patient who's physically deconditioned, we have a patient with anxiety, with depression, cognitive failure. But what exactly is happening in the micro level in his body? So here, there's a concept which we call as perceived fatigability and performance fatigability. So when we look at perceived fatigability, that is a trait. Performance fatigability is more of a state. So it is what it is at that time. And so that's a state. Whereas perceived fatigability is what is actually happening to them, which is more of a trait. So in the perceived fatigability, it is the psychosocial state of that patient, the mood of that person, the motivation that he or she has, the pain, all of these aspects that contribute. And then look at the body homeostasis. Patient is oxygen dependent. He has, poor hydration, blood glucose levels, cardiovascular, all of these dynamics are the body homeostasis. So at rest or during physical activity, all this will contribute to perceived fatigability. Whereas performance fatigability is like I said, a state. So this is mostly during physical activity, where you have your muscle strength, your peripheral factors, your central factors, all of which are contributing. So it is these dynamics of A which actually impact B, or what we see as motor function, cognitive function, and psychological well-being. So consider all these factors, and that is the reason why the patient is fatigued. So now, is there any way that we can control this? And that is where we come to the modulating factors. So what kind of respiratory disease does this patient have? What are the tasks that he or she does? What is the severity of the disease? What is the environment that this patient lives in? What are the precipitating factors? If we could elucidate all of this, and then if we go to D and design new interventions. So can we do something about the performance? Can we do something about the physical activity? Can we do something during acute exercise? All of these factors could help in actually intervening in fatigue. So now, once we have come to this and we say that these are the factors contributing to fatigue, so these are the tasks that I'm going to set for my patient. You also have to be mindful that there is something called patient demands and patient capacity. So what do we mean by patient demands and patient capacity? We mean that there is something called a general demand and treatment demand. So our patient is also living his life. He also has the demands of his treatment. So when we say demands of his treatment, it means you must have given certain instructions to your patients. This is how you have to live. These are the tasks that you have to do. You have to do spirometry so often. You have to do your pulmonary rehab. You do this in good faith. But that becomes a task for the patient. So as the treatment demands and the general demands keep climbing, the patient's capacity after a period of time starts declining, because initially he'll have family, he will have everybody with him to help him. But soon, over a period of time, his resources start depleting. And the illness burden starts increasing. So we have to be mindful as physicians to understand that patient demands and patient capacity are two very important factors. So the general demands, the treatment demands, and the decreasing resources and the increasing illness burden. When this gap starts increasing, and this is what modulates fatigue. And once the patient becomes more and more fatigued, what happens is his adherence to treatment comes down. And why am I focusing so much on this? It's because one needs to monitor fatigue longitudinally. Taking one history of fatigue at one point in time will not be enough. We need to look at it longitudinally. So every visit that the patient comes to us, if we regularly assess fatigue, that is when we will pick it up really early and we can start our interventions early. So this is what I really wanted to emphasize in understanding fatigue. So how do we assess and evaluate fatigue? So we evaluate like how we evaluate our symptoms. We evaluate the severity, the onset, duration, how it interferes with daily life, all of the associated psychological and social problems and underlying causes. I have put all of this in one line, but these are very, very important contributors because a lot of it depends on the background from where the patient is coming, what is he or she as a professional, what are the daily demands in his life, and what is it that he or she expects, and what are their goals of care. Then the functional capacity, which most of you will be familiar, task related fatigue, which is what I think is very, very relevant because the level of my fatigue would be very different from the level of somebody else. So each person to his own, and that's why the task related fatigue is a very nice way of taking history. We also have tools like the visual analog, the numerical rating scales, and of course the performance status of the patient. All of you must be, but there are some screening tools. I'm sorry, ESAS is not a performance assessed status, it's a screening tool for symptoms. Then the KPS tool, then the ECOG, which most of you use. We as palliative care physicians use the palliative performance scale. And the key is that we need to evaluate in every visit. So once we start evaluating and we come to what we call as moderate to severe fatigue, what else do we need to evaluate in the assessment? We are going to look at onset duration. We are looking at all the associated and alleviating factors. We are looking at how it's changing over time and all of this. But along with this, what is very, very important is the disease and the treatment. Because the fatigue levels during an active disease, during treatment, can also be significantly high. There will be a different kind of fatigue which will set in post-treatment. At end of life, we are dealing with a completely different kind of fatigue. When disease recurs, mentally the patient is completely drained, and so that kind of fatigue will be different. When disease progresses, then the burden and the disease progression with its symptomatology will cause fatigue. So what is the key is understanding at what trajectory of the disease and what treatment this patient is on, because many of our treatments sadly increase the fatigue. So what are the challenges that we face? So when we look at it as a symptom, it's a very difficult symptom because it's very ambiguous. There are so many mechanisms. It is so dynamic, it is multifaceted. And most importantly, each one uses their own scale. So we have multiple scales. So even if we want to review all of the interventions that were done, we have had different parameters and different scales in which we have actually seen them. So that is why it becomes very difficult as a symptom in itself. Patient fatigue. Now, can you imagine a patient with a huge illness and that burden sitting, and he actually having the gumption to tell his doctor that I'm feeling tired? That really doesn't count as an important enough symptom for the patient to address to the physician. So unless the onus is on us, unless we are going to ask them, we are never going to get this information out. And as far as physician factors are concerned, it's like that big elephant which is sitting in the room, because I know that my patient is tired, but I also know that there is really nothing that my textbooks have taught me about what to do for him. So what am I going to do? So it is such a subjective symptom. There is a lot of clinical inertia that we have. We are not adequately empowered to deal with fatigue. Most importantly, along with the gaps in knowledge, fatigue cannot be dealt with on an individual level. You need caregiver support, you need multidisciplinary team, you need talking time, you need to spend time with the patient, which does become difficult in our daily practice. But having said that, we really cannot ignore it. So now let us move from treating fatigue to at least managing fatigue. So at least after this session, if we start asking, evaluating, and trying to manage, I think that would be a big task forward. So if you look at it from the patient side, we need to empower them. We need to educate them. The minute you validate a symptom, automatically the patient starts feeling a lot better, because then the patient feels that, okay, this is something that happens to patients. This is something that is not unique to me. And if I try and pace my activity, if I start and resting in between, if I start and doing things the way that they've told me, I can actually start feeling less tired. And from the physician's perspective, it is accepting and acknowledging the symptom, which is also important. You need to identify triggers, and that's where a longitudinal assessment is excellent, is very, very important. So we always talk about anticipatory guidance before the actual problem sets in, a very proactive approach wherein you ask them every visit, and advanced care planning, especially in end-of-life scenarios. And most importantly, you need to work along with a team. It is a multidisciplinary team. You need continuous collaboration. You need good communication skills. You need to train, and you need to work very, very well with your teams to manage symptoms like this. So when you talk about this during treatment, if there is mild fatigue, we usually stick to general strategies of educational counseling, energy conservation techniques. And when we move to moderate to severe fatigue, along with the general strategies, we will use certain focused assessment and we will try and correct the contributory factors to fatigue. We will also start using some non-pharmacological interventions. We will take the help of our physiotherapist. We will take the help of our counselor if needed, and then maybe combine it with some pharmacological interventions. But at end of life, the way we deal with fatigue is completely different. That is when we start eliminating all the non-essential activities. We start conserving the energy for what it is that the patient wants, not what I or somebody else wants. And we stop correcting reports and we actually look at the person as a whole. We maximize the symptom management to the maximum possible. We try and address emotional distress because that distress in the caregiver, in the patient can be very, very significant. We optimize treatment for sleep, and we could consider corticosteroids depending on the prognostication. As far as management of fatigue goes, the highest evidence is for non-pharmacological. I have put in all the references towards the end, so all of you can read up about it. We also have an EBM on cancer-related fatigue, and so all of the references are given in the slides at the end. So the non-pharmacological management is actually prime for fatigue, and among pharmacological, we use very little medication. We do use Megestrol in cancer-related fatigue. We also use corticosteroids in cancer-related fatigue as burst doses. So with this, we now come to our next symptom, which is insomnia. So insomnia, if I need to define it, is difficulty in initiating or maintaining sleep despite adequate opportunity and circumstance to sleep. It is also associated with daytime tiredness. It's again associated with fatigue. You have disturbances in concentration, in mood, you start getting tense, you start getting headaches, you start having GI symptoms, you have a significant impairment of your QOL. And this sleep disturbance should be for at least 3 nights in a week, and it should persist for more than 3 months with night-to-night variability. Having said that, again, we have a lot of comorbidities and risk factors. So you are the experts in sleep disorders as pulmonologists. So that is not an area where I'm going to transgress. But along with sleep disorders, we have psychiatric disorders. We have prescription medications, which itself disturb sleep. We have we have substance abuse. We have caffeine, energy drinks, electrolyte impairments. We also have medical conditions. Now think of our patients who are breathless all through the day, who are with AIDS all the time. You have patients with edematous feet, you have patients with congestive heart failure, you have thyroid abnormalities, you have neurological conditions, and of course, add to that, you also have lifestyle shifts nowadays where people work with different rhythms, different time zones. And so all of these factors and some of these put together will definitely cause insomnia. And I just put up this slide to say that we do have so many sleep disorders, but the insomnia that we're going to talk about here is only going to be the insomnia disorder and chronic insomnia disorders. We are also mindful that obstructive sleep apnea has a lot in common with comorbid insomnia, and that is all for you to actually break down and treat. So in chronic respiratory disease, we have sleeplessness because there is a perturbed respiratory system and there is severe daytime hypoxia and or hypercapnia. There is dyspnea, patient is having cough, he's having secretions. So, and there is a sense of sadness all the time. I mean, you don't like to be coughing even when you have a cold. And what if you have to live with it all your life, 24/7, 365 days? And then you have increased daytime sleepiness. And of course, in cancers, you have direct effect of the tumors, the result of therapy, and various other symptoms all put together. So when we assess sleep disorder, when we assess insomnia, the usual questions that we ask them is, are you having difficulty in initiating sleep? Are you having difficulty in maintaining your sleep? Are you having an early morning awakening? Are you having snoring and excess daytime symptoms? This is regarding the basic sleep history that we take. And then we try and characterize the complaint, whether it's onset, its severity, since how long this has been happening. We also try and document the sleep-wake schedule and keep a log and tell the patient to keep a log, and also document cognitions. Most of this is done in tandem with the clinical psychologist, because after a point of time, the patient starts saying that I know I'm not going to get sleep. That thought that I know I am unable to sleep because this is how it has been itself can cause insomnia. And then we evaluate what are the things that they are doing as daytime function. So we focus on all these three P's, which are the predisposing, precipitating, and the perpetuating factors, along with family history. There are, of course, tools like the Pittsburgh Sleep Quality Questionnaires, and we do have other and the questionnaires that you can deal with. But in principle, this is the history we take. When we look at principles of therapy for insomnia, there are again two groups. You can use the GABA agonists or the melatonin agonists, and you can use the MAO inhibitors or our antidepressants, and the DORA group, which is the dual orexin hypocretin receptor antagonists. So these are the main group of drugs that we use, and this is because it is based on this kind of neurobiology. But the most important therapy and the maximum evidence for therapy, even today in insomnia, is cognitive behavioral therapy for insomnia. This was one of the references for management in chronic disease, or an algorithm that we found. So again, this algorithm also focuses on cognitive behavioral therapy first. And if it is effective, it tells us to continue it. And if it is not effective, then we need to move on to the pulmonary function test, the arterial blood gases, and then you can start them either on doxepin or svorexant. And only if this line is also not effective, you go further and give them benzodiazepines. As far as cognitive behavioral therapy goes, there are behavioral strategies, there are cognitive strategies. So as at our level as pulmonary care, as pulmonologists, as palliative care physicians, we could always start with this side, where we could talk to them about sleep hygiene, which is very important. We could talk to them about their routine. When we talk of sleep restriction, it's not actually restricting sleep. It is trying to make the bed a place where you only sleep. So any other activities you restrict there, and you consider the bed as your sleep time place. So you try and make the atmosphere around conducive to sleep. You try and give them stimulus control, relaxation techniques, good sleep hygiene, things that facilitate circadian rhythm. And then the cognitive strategies, the psychoeducation, this is mainly the clinical psychologist's domain. But the most important thing is that whenever we decide to work on insomnia and sleep, the first thing that we should do is find out why is it that they are finding it difficult to sleep. And when we know why is it that they're finding it difficult to sleep, is it a bad symptom that is troubling them? Is it nocturia that is troubling them? Is it the thought? Is it the thoughts of the disease that is troubling them? So unless that exploration into psychosocial distress is done, we will not be able to move forward. So once we have good control of the physical and the psychosocial domains, sleep will follow as a continuum. And yes, we do have drug therapy that's approved for chronic insomnia, but honestly, our prescriptions are mostly with the off-label drugs, because we try and use these medications for other uses. We try and use them for pain, we try and use them for cough, and automatically the sleep improves. So when we talk about pharmacotherapy, it's also about restricting drugs, because many times we give corticosteroids in the night, which actually prevents sleep. We give and if the patient by mistake has been taking diuretics at night, that is going to upset his sleep pattern. So it is important for us to know that if there is a depressive disorder, and if the first line is ineffective, then we can start him on a sedating antidepressant. And melatonin in the elderly, or we can actually find combinations that can work for other symptoms and also induce sleep, like anticonvulsants like pregabalin can decrease the insomnia and anxiety. Atypical antipsychotics, that's a very common drug that we use, when there is organicity, when there is vomiting, can be used, and that is when it also induces sleep. And so choosing wisely is very important. We need to use medications with caution, because we need to remember that when we are medicating for insomnia, we also have to be cautious about daytime sedation. We have to be cautious about dizziness, about nocturnal confusion, about cognitive impairment, and falls in the elderly. Another good drug here is mirtazapine now. And there is a recent article for evidence in treating cancer-related symptomatology. That's because mirtazapine, we can use it for pain, we can use it for sleep disorders, we use it for anxiety, we use it for anorexia because it improves appetite, we use it for nausea and vomiting, and there is also evidence for breathlessness. But this is, we do not have sound evidence yet, but this is a drug that many of us have found very helpful for symptom control, for multiple symptoms to be controlled. And so it would be an area where any of you pulmonologists can take it up and do a study on. And again, interrelated to sleep is psychological disorders. Why is it so important, even as pulmonologists, for us to identify psychological distress? Because if we actually look into this ourselves, if we retrospect, if we self-reflect, all of us know that if we are distressed in the mind, it impairs our capacity for pleasure, for meaning, for any connect. We lose all of that. And it erodes our quality of life. And what it does is it amplifies our symptoms. So it amplifies pain, it amplifies other symptoms that we have. It causes anguish, not just in us, but also in the family. And these are the kind of patients who will also refuse to take treatment because they're already so mentally disturbed that they say, I'm not going to add on to anything more. And this is also a risk factor for suicide and hastening of death. So when we look at the spectrum of psychological morbidity, we have it all. All our treatments, all our therapies, all our patients, and all the kinds of chronic respiratory diseases that we have will cause morbidity in all domains. So when we say all domains, we understand the physical domain. It causes functional limitations and all the multiple symptoms that are associated with it. Family dynamics are completely disturbed. Now, when we say family dynamics are completely disturbed, we also have to be mindful that this is not just family dynamics that are disturbed as per the disease, but each one of them comes from a family with a history. So in case there is already a psychiatric history, in case there is already difficulty coping in that family, in case the family dynamics are already very, very difficult set of dynamics that is going on, if there is violence, if there is abuse, if there is dysfunction, if there is some kind of unresolved grief, this can happen in families. And if we don't go back into that, we will be losing a significant part of history and our treatment might just not work. The patient coming to you would have abused substances, and today he must be living with that guilt. Why did I do this? Why did I not listen? And the family will be looking at him saying, I had told you so, and look what you're doing to us. So there are so many of these dynamics that are a constant. And there is a significant amount of what we call a spiritual distress, which again is not just related to religion, but it could be related to religion too, but it also is a significant part of why is all this happening to me? Why is it that I cannot live a regular life? Why is it that I have to be on oxygen all the time? Why is it that I have to go, that, I need to make this weekly visit or monthly visit or fortnightly visit to hospitals and spend so much time there? What have I done wrong? Is this some kind of punishment? So all of these are questions that are constantly going on in their minds. Treatment related, our medicines are not great because many of our medicines come with side effects. And in respiratory disease, they depend on life support machinery, they depend on other aids. And more importantly, there are multiple physician care providers. And so if you have multiple physician care providers and then you lack coordination, you're going to mess it all up. So whenever I talk about integrative practice, I always emphasize that you need to integrate care, but you shouldn't fragment it. So if I tell my patient, you need to see the psychologist, you need to see the physiotherapist, you need to go here, I shouldn't be fragmenting it. I somehow have to blend it all into one holistic model of care. That onus is on me and my team. So it's the team which gives the results. But when we are integrating, we should also not fragment care because that can contribute to patient distress. And then the social factors. We always talk about the socioeconomic factors and the lower socioeconomic status in patients. But there is significant distress even in those who come from privileged social backgrounds. And why do I say that? Because you must be seeing it in your practice pretty regularly. You have elderly patients, you have patients who are dependent on oxygen, you have patients who are dependent on aids, who are living on top floors, who do not have access to probably lifts and do not have access to people. All their children are living abroad or their children are living in different cities. So here, nuclear families, elderly couples living alone, and probably single people living alone, depending on or dependent on someone. So it's not always about money, but it's also about the support system that a person has. It's also the belief that they have been brought up with and the availability of supportive services. It takes at least a day for us if we have to arrange oxygen for a patient at home. And actually, thanks to COVID, it's easier now than it has ever been. But even then, so imagine if a patient did not have that kind of support, where will he be running around from pillar to post, trying to access, say an oxygen concentrator at home or devices at home or any kind of support at home? And where is the place in our homes to have all of this? So we need to look at each one of these factors because each of this is a significant contributor to psychological distress. So then when we talk about actual psychiatric disorders like anxiety and depression, we should be mindful that we do not use these words loosely because these come under psychiatric illnesses. Very often they are underdiagnosed, undertreated, or remain even untreated. And we always feel that, we are just not equipped to do that. And when we refer a patient, maybe we lose the patient because if we tell them to go to a psychiatrist, the patient will just stop coming to us. These are real world fears. Lack of recognition, lack of treatment, all of this contributes to negative outcomes. And in the principles of diagnosis, we must remember that these symptoms should cause significant distress and occupational dysfunction to qualify as a disorder. And these are usually diagnoses of exclusion. So when we look at psychiatric disorders, we should understand that it's a spectrum. We have what we call as major depressive disorders and general anxiety disorders. But in the spectrum, we have a huge spectrum of adjustment disorders, which is more of actually what we see. And then we should also not forget that there are anxiety or depressive disorders which are secondary to medical causes. So one should never forget that when we are discussing or when we are talking to our patients. So how do we understand this spectrum? When we look at this spectrum, we'll be able to see that we do have depression, we do have anxiety disorders, and we have adjustment disorders, and this is our normal response. So let's start from the normal response. Suppose something terrible happened to me today. I had a bad day today. So it kind of affects my mood, it affects my state, it affects of how I feel that day. But then this is day-to-day stress. I have learned to live with this. This need not always follow into a crisis. It could get resolved right here, or some issues could move into a crisis, but we still are able to respond normally to this, and we are able to take this in our stride and move along, even when we have a crisis. But adjustment disorders, now think about a situation where you have been diagnosed with a chronic disease. You have a diagnosis on your head. You're going to live with this all your life. The first impact is always shock. The first impact is shock, and then you grieve, and then you vent, and then you are miserable. You go through a lot of emotions depending on the kind of person that you are. It takes you time to adjust. So this is when you see your patients venting with you, talking to you, feeling sad, feeling worried, feeling afraid. They are going through a normal pattern of adjustment disorder. Anyone in their position would go through it. Now, this can happen for 3 months, it can happen for 6 months. But if you feel that this is continuing for way too long and these symptoms are overwhelming the person, is disturbing their daily routine, they are not able to carry on their daily activity, then all the alarm bells in your mind should start ringing. So in the diagnostic spectrum, if you talk about an adjustment disorder, it usually lasts for about 6 months. And you can have a depressed mood with it. You can be anxious with it. You could be fearful with it. Your conduct could change. You could have a mix of various emotions. When you talk about anxiety, when you use the word anxiety, the predominant word that should come into our minds is worry and fear. So worry becomes a constant, and then you're unable to concentrate, you're unable to turn off your thoughts most of the time. You have trouble to fall asleep, you have so many crying spells, you have physical symptoms. All of this becomes the anxiety disorder spectrum. And then when you talk about feeling depressed, according to the ICD-10, your depressed mood or your depressed affect, it's how you feel, you're sad all the time. Anhedonia, where you lose interest or pleasures in anything. It could be a simple task that you do every day, but you just have no energy to do it. You have mental fatigue because of the depression. And then you just have lost interest in everything that you once used to do. You have your appetite changes. You either eat too much or you eat too little. Your sleep, you have sleep disturbances. You live with this constant feeling of guilt, that sense of punishment. Maybe I did something wrong. Why did I do this? And it impairs your concentration, ultimately culminating into thoughts about death and suicide. So this is how this diagnostic spectrum is. So, what are the essentials in the assessment and what are the challenges that we face? So, when we need to assess this, we first always start with exploring what the patient's understanding of their illness is. That it's of prime importance, because how the patient has actually understood this illness, what does he or she expect, what are the goals that they have set for themselves, what are their hopes, is very important when we are dealing with what are we going to do for you. And then we evaluate for all the organic factors that could contribute to the symptoms, like the hypoxia, the sepsis, the medications. We should not ignore these. Hypercalcemia, you can have vitamin deficiencies, electrolyte imbalance, all of these things can contribute to this. The challenges are when we have symptom clusters, which I will just touch on in the end, which will overlap. So you can have a person with major depressive disorder and a neurovegetative overlap in that, and you could have it with advanced medical illness. So what exactly is this patient having? It could be a challenge. You could have depression and anxiety disorders, but the symptomatology could be somatic. So again, it's a challenge. So there are certain boundaries which become really difficult and need a way more thorough assessment. Some helpful questions which we can use in our regular practice as pulmonologists, as palliative care physicians, as a physician in general are: how do we screen for depression? How do we screen for anxiety? So what are the questions that I can ask my patient? I can ask him or her, during the last month, have you felt down? Have you felt depressed? Have you felt sad? Have you felt hopeless? Have you been having less interest or little interest in the things that you do? And then gently, if they say yes to all of this, we ask them about self-harm. If I want to question them about anxiety, or as part of screening, my questions would mostly be as: have you been excessively worried? Have you been unable to concentrate? Have you been able to turn off your thoughts most of the time? And paramount to all these questions would be: is this affecting your daily activity? Are you able to do what you once did, or are you now unable to do what you once did? You also have the PHQ-4 questionnaire, which is again a simple tool which can be used, and with the anxiety subscale, which is the sum of 1 and 2, and the depression subscale, which is the sum of 3 and 4. If you feel that that these are significant scores, immediately that becomes your trigger to refer this patient to a psychiatrist. And along this, if your patients are responding to these tools, you do find adjustment disorders and borderline anxiety, then it's time we start with the clinical psychologist and start the counseling sessions in itself. But these are red flag signs that is helpful to note. And when we look at principles in the management, again, paramount is non-pharmacological, psychotherapeutic interventions, the social support, the family interventions. And even when a patient is terminally ill, but he or she is depressed, it does not mean that we have to give up. There are still interventions that we can work on with the family and with the patient. So just because the patient is terminally ill, we don't need to ignore the symptom at all. And in the pharmacological, the commonly used medications are the tricyclic antidepressants and the various other groups of antidepressants. I have put up a chart which I can send it to you in the PPT. The most important key is how do you choose this antidepressant? Like I have said before, and I'm reiterating, we always choose it based on all the other symptomatology that the patient has. So I would like to use mirtazapine if suppose the patient is also having, that the patient is needs an antidepressant, the patient is unable to eat, unable to sleep. So he has all these and also has an element of neuropathic pain. I would like to use mirtazapine in these patients. We could also use tricyclics in patients when we are controlling neuropathic pain. If the patient has pruritus, along with these symptoms, they will respond to paroxetine or mirtazapine. If the patient has cough, they will respond to gabapentin. So if we kind of choose the antidepressant and try and tackle one more symptom with it, it actually helps the patient. When we look at anxiety, like I said, our assessment should include history, discussions with family and carers, physical exam, and also lab investigations. And the keywords: worry, fear, inability to concentrate. And again, non-pharmacological interventions are what is prime. And you have various kind of therapies. I cannot go into the details of each one of them. It's not my area of specialty. But we do start with things like a comfort bag, like telling the patient, keep a time for worry. If you're worried all the time, then just try. Keep maybe 1 hour in a day when you will worry. Then put all the things that you like the most into a little bag, call it the comfort bag, and say, look at it when you feel scared. And then have a bell next to you. And each one of you knows in pulmonary medicine that dyspnea and the breathing, thinking, functioning model that you've already done, how much anxiety is a contributor to dyspnea. So keep a little calling bell next to you. Make sure that your doors are not locked. There are a lot of non-pharmacological interventions which can bring down fear, which can bring down worry, and actually bring down anxiety, of course, along with good symptom control. Preserve the care tenor, treat the patients not just as a disease, but respect their dignity, respect what they want, treat them with compassion. This is a given. We keep saying it and we keep training everyone with it. We have to tell this to ourselves also every day and be mindful, because many a times when we see too many patients a day, sometimes we can also have a slip. And the various pharmacological interventions are the benzodiazepines and your serotonin specific reuptake inhibitors. Now, coming to the last part of our session today is we dealing with chronic pain. Now, this is really a task in itself. So again, I thought I would focus on how we approach pain as palliative care physicians. So for us, pain is an unpleasant sensory and an emotional experience. As much as it is a physical one, it is a somatopsychic phenomenon. And we always look at the patient's mood, the morale, and what meaning this patient has for this pain. Why do I say that? Because I'm not talking about acute pain, I'm talking about chronic pain, something that the person is living with all the time. And so Robert Tykross's definition is what holds. Pain is what the patient says hurts. So when we look at the types of pains, we have acute, chronic, nociceptive, neuropathic pains. So nociceptive could be somatic, from our bones, from our muscles. It could be visceral pain. It could be neuropathic pain, either because of nerve compression or because of nerve damage. It could be all along the spectrum: procedural pain, treatment-related pain, and pain at the end of life would be different. Pain of metastatic disease would be different. Survivors have a different kind of pain. So you have a whole spectrum of pain. So it's always important to know where is the trajectory of your patient when you're dealing with pain. And so the principles of our assessment is mostly to characterize the complaint and also to focus on what is the pathophysiology of this pain and what is the impact on this patient's life, because that is what will guide our choice of treatment. And the concept of total pain, assessing and reassessing, is extraordinarily important. So when I say total pain, I have to have Dame Cicely Saunders there, because she was the one who brought up this concept of what we call as total pain, just like how we spoke about psychological morbidity in all domains. Total pain affects all domains, and each one of us is familiar with this now, because it is not just the chronic respiratory disease that we are dealing with, but it is the illness experience for that particular person. So we have to start by taking a step behind, keeping the disease in focus, but keeping the person in mind, and that becomes the illness experience. So always think of What is the physical damage that is happening here? What is happening to the dynamics? Who is that caregiver who's standing behind the patient? What is he or she going through? Is this patient angry, upset, and is he going through spiritual distress or emotional distress? So these are things that should be continuously on your mind. And requisites of a good assessment include history, include labs, include the effect of pain, include the effect of what the previous analgesics have been for this patient and what has been their experience, and also what is his goal and expectation. It's not to bring the score from a 10 to a 0, but it is what is the patient's goals and what is the best that I can do. And the most important thing is you can only do this if you have a good, trusting relationship with your patient, and that is for us to create. So some helpful questions in history. We always go as, of course, the site, the frequency of the pain. So we ask them whether it's continuous, whether it's intermittent, how many episodes in between, what is the impact on your activity, how does it affect your sleep, how does it, what are the medications that you're taking and in what frequency. Easier way of remembering it is an OPQRST, where we talk of onset, what are the provocative and palliative factors of your pain, what is the quality of your pain. And I'm sure in every parts of our country, we will have very, very interesting descriptors for pain, and each one will express it in a different language. As you know, chupta hai, chun chun hota hai. So you have so many different ways of pain expression from the patient. It's nice to listen to it, and that is what will actually tell you what's a kind of pain. Does it radiate anywhere or is it referred pain? What is the site, the severity, and what are the temporal factors? We also have different scales to judge severity. We use the visual analog or the numerical rating scale. In children, we can use the Wong-Baker faces. And we also have a map in which we actually put in as 1, 2, 3 if there are more than one pain. And 1 is the area of most severity, 2 follows, and then 3. So we mark it there. And why am I saying all this? Because again, it is a longitudinal assessment. You don't take a pain history on one day and forget about it. And then when we move to character and radiation, this is what will tell us what is the kind of pain. The pathophysiology will actually come through the character and radiation of the pain. You can have questionnaires for neuropathic pain. This is one of the common questionnaires that we use, the DN4 questionnaire. And then the timing of the pain, we also tell the patient to maintain their own time diary. We tell them to write down what troubles them, at what points they have breakthrough pain, at what points they have intermittent pain, at what point they have episodic pain. So we explain all this to the patient and we tell them to actually write it down. So when we talk about pain assessment, the word I would like to use is, it is synchronous and sequential. Why synchronous? Because as the patient is describing the pain to you, the doctor reflects on the cause, on the mechanism, the contribution of the non-physical factors, and is actually coming to a conclusion on how I'm going to manage this pain. And it has to be sequential, because only then you will know how your medications or your treatment is working. Management is, of course, both non-pharmacological. Pharmacological is based on the type and the intensity of the pain. The WHO analgesic ladder is what we use day in and day out. So we start with non-opioids and adjuvants, then move on to the weak opioids and then the strong opioids. But what needs to be remembered is 2 things. One, the psychosocial spiritual support will move all along the ladder. The second thing is, you do not have to go to the ladder one step after the other. Severe pain merits step 3 right away. So this is how we usually start, but like I said, you don't need to climb it step by step. The principles of the WHO ladder is that we use it from by the clock, by the mouth, by the ladder, and an individualized approach. Because we need to remember that giving an injection is not going to help this patient, because he's going to have chronic, constant pain. So this is the list of the non-opioids and opioids that we have. Tramadol comes in the step 2. Tapentadol is now a step 3 opioid. So tapentadol, morphine, and fentanyl and methadone are what we have in our country as step 3. In the non-opioids, we have paracetamol, which is the key for most of our pain management. We do have NSAIDs, which we do not use, which we use in very specific conditions. But otherwise, the usual combinations that we use in cancer pain is paracetamol and opioids. And of course, adjuvants, because for neuropathic pain, we need our adjuvants like anticonvulsants, antidepressants. These are what we use. And then we also have adjuvants like antiemetics, which need to be given along with the opioids, the antispasmodics, which we need to be given for some kinds of visceral pain, antibiotics, anxiolytics, antacids, bisphosphonates, all of this. The guiding principles are that chronic pain is constant, it needs regular medication. We need to choose the routes of administration. So, a patient on end of life care, we might choose to give them a subcutaneous or an intravenous medication. So, we need to choose that. And many times we see prescriptions where a sustained release morphine has been given, but there is no immediate release with the patient, which is actually not a good prescription at all, because when we give sustained release medication, we also need to give them an immediate release one, because they need that medication to take intermittently whenever they have breakthrough pain. Switching opioids, managing the side effects, and assessing total pain is our responsibility when we prescribe opioids. So now, as I come to the end of this session, I just thought I'd highlight, you must have realized along the way, when I started with fatigue, insomnia, moved to psychological symptoms, and then to pain, you must have realized how interrelated each one of this is. And that is why in our assessment, in every assessment, we use what we call as the Edmonton Symptom Assessment Scale, which is one of the screening tools. And here you can see all the symptoms that I just spoke about: the pain, fatigue, whether they're depressed, anxiety, sleep being some of them. So when we do this every day and we see the symptoms going beyond 4, then we know that our mind has to start thinking. So even that visual impression of the scale is enough for us to know whether this patient is having difficult symptoms or symptoms that can be easily managed. And when we look at this on a regular basis, we will find that our symptoms come in clusters. Very often, we see symptom clusters. So in COPD patients, there are 4 distinct anxiety symptom clusters. So there will be somatic distress, there will be fear, there will be nervousness. There's something called a respiration related cluster, like dyspnea, cough, and anxiety. So you can have a pain, depression, and fatigue cluster that you see in lung cancers. So these clusters are important and interesting, because if we bring down the pain, we can automatically bring down the other symptoms too. So that is the importance of recognizing symptom clusters. There is also a recent article in Chronic Obstructive Pulmonary Disease about symptom clusters, and how there were 2 themes in this study. One was a psychological symptom cluster and one was the respiratory symptom cluster. But because of the heterogeneity among the patients and the instruments and the statistics, we really couldn't get adequate data. So I would like this to tickle your brains a little, and maybe an area of collaborative research could be COPD associated symptom clusters that each of you could take up as a study or do a multicentric study. And finally, we come back to integrating care. Why are we all here today? Why are we spending this evening sitting together as pulmonologists, palliative care physicians? Why are we doing this? Because finally, we want the best for our patient. And how are we going to do this? We're going to integrate care. So I have just put up some evidence that we have found from respiratory, in the context of chronic respiratory disease. So this is one of the models where we need to be mindful that as the complexity of symptoms keep increasing, we need to change our levels of care. So if we start with a level 1 for our regular patients, where you can provide them with generalist palliative care and specialist respiratory care, we might have to move on a bit as the patient's symptomatology gets worse. So as the symptoms get more complex, we go into level 2 and then into level 3, where we will start involving specialist respiratory care along with generalist and specialist palliative care. So this is called movement between levels. If the patient is doing better, we can always come down to level 1. So this was one model that was described. And the other models that have been described is indications for palliative care. So as a pulmonologist, when am I going to refer my patients? So I could have my cutoff. I could use symptoms. I could say if I have complex troublesome symptoms, maybe I'll take the help of palliative care physician. If I have unmet family caregiver needs, if this patient is having too many hospitalizations, if they are going into acute inpatient care for respiratory failure, maybe their lung bells have started ringing, if they are on oxygen therapy, if there is a deterioration, if they are not able to attend pulmonary rehab, these could be my triggers. or I could have a working model in my own unit. So here is an area where you can creatively design your own models for integration. And this is in the same article, they have described the lived experience of patients. So as we are talking about what we can do as pulmonologists and respiratory care and palliative care physicians, it's also important to understand what the patient wants. So this article has described the lived experiences. Patients want to understand their disease. They want sustained symptom control, and the psychosocial effects are also significant. So these are domains that we need to address. When we need to address these domains, we need to have a system in place. And what is that system? We cannot escape having a multidisciplinary team to do all of this, because we cannot do this individually. So there is also a nice article on interstitial lung disease and what are the needs of patients in interstitial lung disease, which has been described beautifully in this diagram. And it also talks about patient education. It focuses on patient education, which is very, very important. And there is also a flow chart over here, which talks about what is the impact of diagnosis and what is the immediacy of palliative care conversations and how we can follow this and how we can have a disease behavior-based algorithm for interstitial lung disease. And there is also a beautiful ABCDE here, which says we need to assess patient needs. We need to back them up with good education and self-management and pulmonary rehab. We also need to give them comfort care and address their comorbidities. We need to give them disease-modifying treatment and also planning end-of-life care. So I think this ABCDE forms the crux of what we have been talking about today and why we need to integrate palliative medicine into pulmonology. So when we form our care plan, we don't forget the history, we don't forget the assessment, we have a good therapeutic approach, we find out from our patients what is it that they want, we talk about prognostication. So if we put all these pieces together, we have the pathophysiology, we have the psychosocial, we have the pharmacological, we have the non-pharmacological, we have the prognostication, very important pharmacoeconomics, and of course the practice of medical ethics, because finally I'm here not to do harm to my patient. Team building is very important. When we talk of integrative practice, we have to have the generosity of spirit where we need to network and collaborate. You have your strengths, we have ours. How are we going to put all this together in improving patient care? So that was what this was about. And thank you so very much for this extremely patient hearing. And we will be ready to take on any more questions or share your experiences. Thank you very much.
I think you've heard enough of me, and I don't see questions here. So would you like to unmute and ask or discuss any challenges that you all face in your practice? Rajalakshmi, are you there?
Yes, ma'am, I'm there. So meanwhile, I will say that I've heard about the recording we shared. Dr. Vidya have shared.
Yeah, I don't have a problem with it. You could share it.
I can share it.
But I would really like to hear from you. I mean, how often do you see fatigue? How often do you even ask about fatigue, or the patient says, I feel tired, and it's like, okay, you know, are you finding it difficult to breathe or coughing? Because those are the easier things to deal with. So I really would like you all to. Divya, since I can only see your face and Mr. Shahjahan's face, I am going to have to ask you to unmute and say something. Could any of you unmute and ask any questions that came to your mind, or was it something that you couldn't really relate to?
Fatigue is a real issue among our COPD patients as well as ILD patients. We used to see them regularly on a day-to-day basis, actually. So to address the fatigue also very difficult, because many a time they have anorexia, maybe associated with the depression, anxiety, many things are there. We
Mhm.
can only offer them until now. We can offer them, ask them to take good food, protein diet, reduce carbohydrate, multiple small feeds, etc., and also supporting them. Okay, you will be okay like that. Symptoms can be reduced to greater extent than that. But apart from that, this medication used for fatigability or even for chronic breathlessness, we do
Hmm.
not have much options until now, because the palliative care in respiratory medicine is only emerging.
Hmm.
It is not a just like medications or pulmonary rehabilitation. Nobody used to practice on a daily basis because nobody is trained actually. That is it. I'm a senior teacher in medical college in pulmonology, but still, even myself got not that trained. This is the first time I got a formal training.
Yeah. So thank you for sharing that, because just like what you said, the easier things to say is food and eat and all of that. But now that there are resources for this and you have people who can do it, it would be nice to work in teams, because very often food becomes a huge source of distress. Because if you tell me to feed my patient, as a caregiver, I come back and tell you he doesn't eat. And the patient is saying all the time you talk about food, and that is actually a cause of contention in the house. It becomes a big bone of contention and there are fights. And I can also see that question about non-pharmacological management. So this conference, we presented a poster on non-pharmacological methods of management in fatigue and in breathlessness. We have the highest evidence for non-pharmacological management. And in our OPD, we've actually made a simple chart. So level 1, mild fatigue, moderate fatigue, and severe fatigue, and what we are supposed to tell our patients. So first thing is education, because to tell someone that fatigue is a symptom itself, and then to tell them how you pace your activities and how you keep moving. Because because of fatigue, if you completely rest, you're actually adding to the fatigue. So what we try to tell them is how little bit, your paced activity, what you should be doing as routine. So we work very closely with our occupational therapist, physiotherapist, and we have created it in our own department. And we actually presented a poster which won a prize. So we make sure that all our patients get this. And the best thing is that we can train our nurses, we can train our, our support system staff to do this. You may not have to do this for every patient, but you can train them. So they could be the ones talking to them when they are waiting for you in the OPD. So non-pharmacological is extremely effective. And I think it has the highest evidence and we should practice it. I hope that answers your question, Dr. Suresh.
Any other questions? You can unmute from your end and speak. We don't have a case presentation today, so I think we can have another 20 minutes of discussion itself.
Oh, there is no case presentation today?
No, ma'am, no.
So how many of you find it difficult to deal with anxiety, with depression, with all of this? At least I hope from the session you would find it easier by at least asking those questions. So, at least asking them, how are you feeling? Because we always talk about open-ended questions, exploring concerns. So how do you feel? Are you sad? Are you able to do what you did? Because once they start saying no to those things, those are the triggers that we should be able to pick. So will that be possible? I am really wondering, am I looking at a blank screen or are there people behind? I wish some of you would unmute and talk, because it's really helpful to hear from you.
Good evening, madam. This is Dr. Suresh.
Hi.
Ma'am, how practical is it to follow all this in a government setup? How much time we can spend for each patient?
I'm happy you asked me that, because I work in a very government setup. I work in a tertiary cancer center. And see, if I'm seeing 40 patients in my OPD every day, at that point, I'm not going to need all of these questions for all my patients. So there will be a triage. So there will be a system where some of them will be my follow-up patients who I may not I will do the ESAS for every one of my patients because that's a given. We do the ESAS for every one of our patients, and we look at the symptom control if it's adequate. But if you find that the symptom control is not as adequate as it should have been, if fatigue has become a problem, if the trajectory of the patient is changing, if suppose the disease is becoming, there is disease progression, you are actually seeing more hospitalizations, you are seeing the symptom burden increasing, those patients, you will need time. So if you are alone in a private hospital, in a government hospital, like I told you, if you have your nurse, the best thing would be is to tutor the nurse. And non-pharmacological methods for fatigue and breathlessness is something which every patient needs to hear. Like we teach them pursed lip breathing for breathlessness. We teach them how to pace activity. We have actually kept a card in the OPD with mild, moderate, and severe. And those who can read, we give it to them to read. Those who cannot read, we explain. And the next visit, when they come back to us, instead of us telling them, as we are writing, we tell them, okay, tell us what you're doing. And we hear it from them. So if you ask me, I would say it is the attitude and the will to do it. We can make it possible because every patient does not need everything, but there will be some patients who will need most of it. So it is possible.
Thank you.
Good evening, madam.
Yeah, good evening.
Yeah, myself, Dr. Ananda Joseph. I'm working as assistant professor at the Vidya Viswanath College. And first of all, like Shahjahan sir said, it's a first opportunity for the pulmonologist here to have a palliative care approach in dealing with patients. We all are like in COPD and all. We all know that there is limited drugs available, and with that we are dealing the patients, and most of the patients are unsatisfied because initially they will get symptomatic relief and all, but after a point of time, every doctors, they will be seeing every doctors, and each one will be prescribing different company drugs, but the result will be same. So depression is the major issue that we will be facing. And one thing I have been seeing is that initially, as I said, initially the symptom gets controlled by drugs, and they get a false hope that the disease is actually treatable, and after some medication they will stop it and like that. But as the disease progresses, their mental strength also decreases, and they will reach a point like there is no cure for the disease at all. And at that time, they will become so much anxious, depressed and all. So at that time, they show a little bit disbelief for the treating doctor also. Like, what we say.
You can say in Malayalam, Mansalam, yeah. But I can't speak in Malayalam.
Like, treating the doctor to disbelief out. Like they will be getting Derafilin, salbutamol, etc. initially, and they are so cheap. And relief the doctor heavy medication costly medication treatable. So patient doctor relation.
Okay. So you actually brought out a very nice point. When do you think this will happen? That is why the key, I don't know if you have finished your classes on communication, and also what I mentioned is expectation. So when we start, if we are seeing the patient for the first time, very enthusiastic, listening to the history, oh, I'm going to give you this, then that is when you have raised his expectation. But if you have been honest upfront and said, okay, so this is how it is, because we do this all the time with cancer. Again and again, I'm telling you that most of my examples come from cancer because I work in a cancer hospital. So there, right in the beginning, when patients are doing well, and most of our patients with lung cancer are doing so well today because of the therapies. But at that time, I don't say, oh, great, you have good symptom control, everything is fine. We never use those words. We always tell them, see, our medicines are working for the symptoms. How are you feeling? What is it that you know about your disease? And we keep using the word, there is no cure for this. We are only controlling. We are only controlling. So that word control should be used every time. Even when the patient is well, And even when the patient is unwell. And then we say we are doing our best, we are only trying to control, but if things get bad, and if you notice that hospitalizations are increasing, your alarm bells have to start ringing. That is where anticipatory care plan, all of this comes. And then you told me about inexpensive medications, patient faith. Morphine is the most inexpensive drug that we have, the most inexpensive. But when I give it to my patient, what I tell them is, in Telugu, I say the Bangaram Laga, like this is like gold. You try it. And I always give them the first dose in the OPD and I make them sit for half an hour outside and then come back, because that is what increases their confidence in that drug. So any drug, it may be inexpensive, but it is how you put it across and how you train your nurses to tell them about the medication. Like these are medications, like when patients have asthma, when patients have your COPD, you tell them, you carry this kit with you wherever you go. You carry these medications. They are the ones. So I always feel that we don't need to say, oh, I'm feeling sad that this disease, I can't do anything more. You're still doing it for your patient. They will appreciate that. So don't ever think that they are not going to appreciate it. And when somebody's asked a question here on sedatives in non-invasive ventilation. So in our practice, we usually, okay, yeah. So in our practice, mostly we use these towards end of life care and an intractable breathlessness. That is what we use this. And over there, we use midazolam along with opioids. That is what we use in our practice. But I know that respiratory practice, it would be different. And how you will be using it will be dependent on how your patient has been seen so far and what are the other drugs. But when we deal with breathlessness in our scenario, our most important drugs are midazolam and morphine. So this is what we use towards end of life. Because it's short acting, we initially start with intermittent doses, and then we sometimes put the patient on an infusion. And if the patient is already on an opioid, then we put them on an infusion with the opioid.
Ma'am, may I?
Yes, please, Gayatri.
Ma'am, actually, your presentation was awesome. Like it covered all the aspects, ma'am. So thank you very much for the presentation, ma'am.
Yeah.
And one most important thing is I have a patient with neuromuscular disease, motor neuron disease. This patient is not able to express his pain. So it becomes really difficult in day-to-day practice to assess what exactly for what he is. So these kind of patients who are mute, aphasic, stroke patients, so how it is difficult for you, and is there any other way by which we can assess their pain and other aspects, ma'am?
Yes, actually, there is a whole section on neurology palliative care. I think it would help you to gain some insight there. You do have scales even for these patients. You can make out the grimace, you can make out, and another thing is look for deep pain. And if you feel that the patient is not comfortable all the time, the easiest thing to do, if you have your patient under admission, they always say is give paracetamol and see the response, and give IV paracetamol and see the response. That's what they say. And there are charts. I could send them across to you for those with neurological. And you can ask Rajalakshmi. She can send you a link to one of that, because
there is a paucity of expression. We are not able to.
You are not able to express. It is very difficult.
Whether they are happy with the treatment, how they are feeling, their sleep. Nothing we could assess. Where it is paining, they are not able to localize. Also, they are like babies.
Yeah.
So
right.
It becomes very difficult to address the other aspects. If they are breathless, at least we can see by the respiratory rate, we can check by the saturation. But when it comes to pain, they are all with the contractures and all that. So we are not able to assess only what is happening to the patient, where they went wrong. They are not able to express. It's like managing a baby only.
No, you're very, very, very right. It is very difficult. And that is when we really find no reason for distress, then at that time, in the sense when we are not able to assess the reason for distress, we usually give a trial with paracetamol. And that is what evidence also says.
Oh.
I'll send you that. If I have one of those, I'll just put it across in the group.
Thank you, ma'am.
You're welcome.
Thank you.
What are your most common symptoms that you all deal with? COPD, ILD?
naturally breathlessness.
Okay.
The
And
first and but at the same time, fatigue is also equal. That they often do not tell unless you ask them, are you tired or like that, or the caregivers tell. But the breathlessness is evident. Actually,
evident.
patient is breathless. It is evident. But the fatigability, you have to inquire whether are you fatigued or not. But the problem here is that whenever we talk about palliative medicine, it is synonymous with the cancer. So the public awareness on chronic respiratory illness and palliative medicine should increase. Then only people will realize. Then only caregivers will also understand. See, I often tell the unaccepted or expectation, especially those with the terminal care. Doctor, when you do something or you whatever medication, a group of patients, they are affordable. But actually, we have limited medication to offer. Or maybe in a NIV or whatever, home ventilations, etc. But still, nobody is digested with the word palliative care in chronic respiratory. That has to be changed. So
then
the
use it, use supportive. If it helps you, use supportive care, which is what all across oncology people have done. Though I honestly feel there's nothing in a name. We say palliative services, our patients come to us for early pal care from the beginning. Of course, like what you say, it is synonymous with cancer. And so for it to get recognition in respiratory diseases is going to take time. And I think that is where if all of you have generalist palliative care, like if you start doing it, you all will be the ones who can in your community, because you don't really need in your practice, if you have generalist palliative care and then you have someone to send to when you have, other concerns, you team with a psychologist and an occupational therapist or a physiotherapist, you're already having a team, and that's how you integrate it. So I think I'm sure it is not difficult for you at all, but you need that little time. And I always believe that somehow, because we also see a large number of patients, but you can do a lot in 5 minutes with eye-to-eye contact. If we dissociate ourselves from the computer, sit at eye level with our patient, and the easiest way to start with is, what is your routine? The minute the patient says, I get up, I do nothing, I'm just lying down all the time, and I have, that you are now looking at, causes for that. Like there is already fatigue, there's already query depression setting in, there is a cause for all this. But if they say, no, I'm able to do this, I'm able to do that, automatically performance status is good, then you go with your symptoms. It does not take more than 5 minutes, 5 to 7 minutes, if you train yourself and, apply it for your patients. So I think it is possible. And once you start doing it, you'll enjoy it, because then the profession of the patient, what they want, so all of that becomes like you're talking to another human being, not just somebody with ILD or somebody with COPD.
Madam, please share your experience with post-tubercular chronic respiratory disease patients.
I really have no experience in post-tubercular chronic respiratory disease. You will have to ask Rajam, because I told you I'm from a cancer hospital. So all my experiences with cancer. But all I can say is that we do see patients who come to us with fibrosis, with radiation-induced fibrosis. I mean, that's the only parallel I can think, where you do not have disease, but you have fibrosis. And because of that, the patient has severe symptoms. They have respiratory symptoms, they have breathlessness, they're walking around with a concentrator all the time, and you're telling them that they don't have disease, but this is the result of treatment. So the psychological impact is huge, the physical impact is huge. And if they don't have disease, they live for a long time with this, but finally succumb to it. So that's the closest parallel that I can think of. But again, I think here again, we use a lot of non-pharmacological, because it's very, very hard for them to live with oxygen support all the time. That's what we've seen in our patients.
Madam, any training for doctors in non-pharmacological management?
Any training, meaning we can have a session on that with a rehab person. Would that help you? I can talk to Pallium.
Yes, madam, definitely.
Because we have very good rehab, even Pallium will have, but that is again something. And I think you would prefer non-cancer, right?
Yes, ma'am.
For non-cancer, because I can see that most of your questions are coming from non-cancer. So I think that will have to be planned, a non-cancer and rehab. So a combination of occupational therapy and physiotherapy which you can use for, see, non-pharmacological, typically for breathlessness, what we follow is pretty straightforward. One is, that is where we use the breathing, thinking, functioning model. And that is the same as in COPD. And that's what evidence says. So breathing, thinking, and functioning, you have to improve all these three aspects. So when we look at the non-pharmacological interventions, it is how do you improve breathing? So you use the pursed lip breathing, you use those breathing techniques. But then now when you talk about functioning, you talk about energy conservation, you talk about pacing activity. So what we tell our patients very simply is that space your activities throughout the day. If you're going to even wear a sari, we teach them how you can sit down, first wear your blouse, then after that you can take your time and split every task. So we actually tell them how to do it, have a bath, all of that part we talk to them. Second is, if they are actually working, then we tell them how to divide your day and take adequate periods of rest. And then even food, so chewing your food, because that can increase breathlessness. So we try to tell them to make it softer and try to take smaller intervals. We take food, and that again helps them. Then the use of laxatives, because straining again causes breathlessness. So we tell them to use laxatives so that the passing of stool, and most of our patients are on morphine or on opioids, so it really helps them to do it. So breathing activities, and then taking time off, pacing activities, concentrating on how you eat, and then how you pass motion. Then in the night, how you have a bell, how you leave the room open, how you leave the door of the bathroom open, how you use walking aids if you need them, whatever aids that you can, that's what we look at the pharmacological ways. And again, there is a very nice article, the breathing, thinking, functioning model from Cambridge, which had actually divided it into these three domains. So if you've had your session on dyspnea, it must have been covered. Otherwise, I can send that across too. So for each of you can create it based on the needs of your patients, and then train your nurses to do it, because it's very helpful. Did that help? I just
Thank you, ma'am. Yes, ma'am.
I went on a long monologue with it. And the same thing we have for fatigue also. So education, counseling, how you talk to them, pacing activity, exercises, conservation. At the same time, exercise and conservation. And again, yoga, there is evidence. So you can integrate yoga into your practice.
Yes, ma'am. So I'll be happy if you share that.
Yeah, I'll share that article, and I'll talk to Palyam. I think Rajlakshmi is already here. Rajlakshmi.
Yes,
I think that's a very useful suggestion, because most of these are non-cancer palliative care. So if we can have one session on non-pharmacological.
yes, ma'am. Yes, we can talk to Dr. CZV and Dr. Rajan.
Yeah, so you can have occupational therapy, physiotherapy, and kind of keep the most important points that every patient should have. So they can train the nurses or their or the staff to do accordingly. And someone's asked, how commonly do we need to involve the psychiatrist? Well, psycho-oncology, again, because I'm oncology, I'll talk about psycho-oncology. So clinical psychologists, psycho-oncologists, we involve in quite a significant number of patients, say about 40 to 50% of our patients, because we also do counseling, a part of it ourselves. So next level will be psycho-oncology. Psychiatrist is when you are, that is why those questions on anxiety, depression, if you are seeing loss of interest, sadness, crying, thoughts of committing, of that, I do not want to live and I feel like dying and I have thought of this, or the family has come and told you that they have suicidal tendencies, then definitely psychiatrist. But it would be a smaller fraction, say about 2 to 3% is what I would say in my practice needs psychiatry. But psycho-oncology and clinical psychology, a good 40%. And again, anxiety, worry, loss of concentration. So these are things that you need to talk about. And maybe you will need a little more than that, because a lot of we are trained in some aspects of counseling, at least till adjustment disorders. So if you haven't been trained, then you will need a little more help. But if you have a clinical psychologist, that works very well for a start. And the clinical psychologist can also guide in non-pharmacological techniques. Any other questions from any of you or comments? Where are your areas of practice? I can see Kerala, and then where else are you all from? Which are the other places?
Andhra, madam.
Andhra. Who's from Andhra?
Suresh, Nellore.
Okay, Suresh, you're from Nellore?
Yes, ma'am.
All right. And I'm from Visakhapatnam. That's why I work at Homi Baba Cancer Hospital, which is a unit of Tata Memorial. So,
Hello.
Visakhapatnam. And Dr. Shahjahan, you are from?
Myself, Government Medical College, Chalappuzha, Kerala.
Okay, Chalappuzha, Kerala. All right.
Pulmonology.
Okay, pulmonology.
Southern part of Kerala.
Yeah. Okay, there is somebody from Telangana and someone from Bangalore. So that's nice. Anyone from the north? I don't see them here. Yeah, Pondicherry.
Yes, ma'am. We have one person from Haryana. Yes, Delhi is there. Yes.
Okay. All right. Delhi. Yeah, Ayush Pandey is from Delhi. Trivandrum, Chennai. Nice. Do you all have access to palliative care physicians where you all work? In Kerala? I'm sure you will. But in any other place? Bangalore, there are plenty. So I think Bangalore, you don't need to worry.
We don't have any access to Nellore.
Where? In Suresh, where?
Nellore.
Nellore, yeah, you're telling Andhra, I completely empathize with you. We are actually training the district hospital doctors. We're trying, Pallium is also involved, and so are we, but it's really, really been hard. All right, so best wishes all of you. If you don't have any more questions.
Thank you, ma'am.
All right, and Rajalakshmi, do you have anything to add?